to be part of this session, and I just want to try to make myself available in any way as a resource person. So very happy to engage with any issues you'd like to raise. I must say I'm feeling very much my grey hair. I'm now been out of the directly clinical scene for a number of years. I'm still actively involved in the field of medical ethics and in writing and teaching about technology. But I had for many years, I worked as a consultant neonatologist at UCH, and we were particularly interested in the use of ultrasound. In fact, UCH was one of the very first places in the world that started doing cranial ultrasound. And in fact, the story as I heard it was that when they first started using cranial ultrasound, it was just after the first CT scans of babies had occurred. And as you know, a CT scan produces an axial picture of the brain. And therefore, once they came across this with this new transducer to get a picture, the natural thing to do is to hold it on the side of the head and to try and get an axial scan. And I understand that the team at UCH were trying to take these axial scans and not seeing very much and staring at the screen and saying, oh, I think I can see the ventricles and so on. And after several months, one of them said, hang on a minute, there's this hole at the top of the head. Why don't we try putting our probe up there? They put the probe on the fontanelle. All of a sudden, they could see an image. And it was literally that kind of trial and error. So they were one of the very first places to start getting ultrasound images. And one of the very insightful things that my predecessor, who was Osmond Reynolds, who was one of the great pioneers of neonatology, he said, what we need to do is start a prospective follow-up study of premature babies. And what we will do is we will record the ultrasound scan, and we will then follow the children, the premature babies, all the way through childhood, and work out what is the objective relationship between the ultrasound appearances in the first weeks of life and the long-term outcome. So I'm going to share my screen now, and so that the follow-up study that I'm basing my work on, and I became part of it when I joined at UCH in the 1980s, but it was actually set up in 1979, and the aim was to define the relationship between ultrasound and the neurodevelopmental outcome. And I'm going to focus on the results from the UCLH study. I mean, there have been a whole number of other prospective follow-up studies doing similar kind of studies, and they've all shown very similar findings. So although there are slight differences in outcome, they're all basically showing the same message. But if we just look at this particular, now quite an old cohort, they recruited all infants less than 33 weeks, and they were followed up all the way through to 8 years. So and in fact, the study continued, and even today, there are now adults who are in their 30s, ex-premature adults, who are still being followed up. They're having MRI scans, they're having detailed psychiatric assessment and psychological assessment to see how that very early ultrasound pictures, how they relate to long-term outcome. And the decision that was made, and I think it was a helpful decision, was that instead of just trying to describe the lesion and then remember what all the different outcome figures were for different lesions, that for clinical use, the best thing to do is to just use this rather simple division of the ultrasound appearances. And so there's low risk, there's high risk, and then, you know, because in medicine you always get this sort of ragbag in between, which are not one thing or the other. So if we start first of all with high risk down here, a high risk ultrasound scan is where you end up with loss of brain tissue. So, and that's either cysts, such as a porencephalic cyst, which is what you would expect after the so-called grade 4 hemorrhage, or occasionally what you can see is obvious global atrophy of the brain. And not surprisingly, it turns out that if you actually lose brain tissue, this is permanent loss of brain tissue, then you come into a high risk category in terms of outcome. And then looking at the data, the other group were the low risk scan, and the definition of a low risk scan is either where the ultrasound appearances have always been normal. So one thing to emphasize is that in order to assess the ultrasound appearances, you need to do more than a single scan, obviously, because a single snapshot can be quite misleading in a baby, in a very premature baby. And the ideal is to do repeated scans, particularly in the first week of life. In fact, our protocol, although it was the sort of standard of excellence, was to do daily scans throughout the first week in order to see the evolution and the changes of the lesions in the brain. And then following after that, we did weekly scans until discharge. Now that may be too much. Obviously, you need to decide in your own setting and with your own resources what would be appropriate, but that would be the optimum, to do daily scans initially and then weekly scans. And the risk category comes from how the scan evolves. So if the scan remains normal throughout the whole period, then that would go into the low risk scan. But what our data showed was that if you had an uncomplicated hemorrhage, and that means a hemorrhage which appears, intraventricular hemorrhage or a germinal matrix hemorrhage, and then resolves and goes away, and the brain scan appears normal after that, then that also comes into the low risk category. Thirdly, if you just have parenchymal echo densities, but nothing else, and they don't go into cysts, then that would be a low risk scan. And finally, if you have mild degrees of ventricular dilatation, I want to emphasize this is not talking about hydrocephalus, but it's where you look at the ventricle and you can see that the ventricle is definitely dilated, but to a minor degree. That also comes in that low risk category. And then you get this ragbag group, which is the intermediate risk category. And when we looked at the data, what became apparent was that if you had 2 or more of the low risk lesions, you came into that intermediate risk. So for instance, if you had both an uncomplicated hemorrhage and ventricular dilatation, then your risk goes up. Or if you had, for instance, a hemorrhage and a flare, your risk would go up. And the other category is where you have hydrocephalus, which is stable, but there is no cystic changes. And so that means that's a hydrocephalus where a ventricular peritoneal shunt has been inserted, or otherwise it's spontaneously stabilized, but there is no clear loss of brain tissue. That also comes into that intermediate risk category. So when you look at a cohort of extremely premature babies, or very premature babies, in fact, this cohort is everything less than 33 weeks, so it had quite a lot of the more mature babies, you tend to find this pattern, and that is that the vast majority of babies come into the low risk category. In our study, it was about 75%, 3/4, and less than 10% came into the high risk category. And then you had about 20% in the intermediate risk category. You know, it's very important to remember this as neonatologists, because it's when you practice neonatology on a NICU, the babies you tend to remember are the bad babies, the babies who have terrible brains. And what you forget are the large numbers of babies who sail through with low risk brain scans and who do extremely well. And so it's just important to remember that balance. Actually, the ones who have really bad scan appearances and high risk scans is a small proportion of the total. And then we followed up all these children, and we threw the book at them in terms of both neurological assessment and also developmental assessment. And we basically looked for children who had any kind of detectable abnormality on testing, and we described that as an impairment. And then we looked particularly at those who had a disabling impairment. That means something detectable which was causing a significant reduction in overall function. This is important, again, just to understand these definitions, because there's a lot of confusion about what we're talking about. So for instance, a child who you see at 8, an ex-prem child, and who on examination definitely has abnormal tendon reflexes, say some clonus or something like that, would go down as an impairment, even if they are walking completely normally and mobile and able to run and jump and so on. Nonetheless, they have a detectable abnormality on neurological examination, so that would be an impairment. If, on the other hand, they had significant motor difficulties, that would go down as a disabling impairment. So, for instance, cerebral palsy of any kind would go down as a disabling impairment. Similarly, somebody who had an abnormality, for instance, of eyesight, of myopia, but which was correctable with glasses, would go down as an impairment, but it wouldn't be regarded as a disabling impairment unless it was actually interfering with their life. So, here is the crux and nub. If you look at the prediction of outcome of 8 years and concentrate on this column, because this is what parents are interested in. Parents aren't interested in whether the tendon reflexes are normal or not. They're not interested in whether you can pick up some subtle abnormality. What parents are interested in is, will my child be in some way disabled? And the answer was, if you've got a low risk scan at 8 years of age, there's a 6% chance of a disabling impairment. Contrast that with a high-risk scan where you've got a 74% chance of a disabling impairment. Now, just also remember that when we talk about a disabling impairment, if you talk about a disabled child to a parent, the most natural thing is they will think of a child with spastic quadriplegia in a wheelchair. That to them is their image of what a disabled child is. It's important to realize that when you look at these statistics, they're not necessarily talking about that degree of impairment at all. They're talking about, you know, a child who had a monoplegia with one arm, for instance, that was significantly reduced, would go down in this kind of outcome as disabled. And so it's important, again, to help parents to understand that disability covers a complete spectrum of outcomes, ranging from absolutely catastrophic through to relatively mild and something that the child can cope with remarkably well. So that just it shows it. If you look at the question of extra educational provision, this is what our statistics show at IQ. Again, it shows that the low risk scans have a 17% of extra educational provision. The high risk scans have a 75% chance of extra educational. So again, same kind of picture. If you've got a high risk scan, you have definitely a high risk of having a requirement of educational difficulties. And again, if you look at the IQs, you can see a definite relationship. But the important thing to remember is that these, and look at it, these SDs are very large. That's just one SD. And so what it shows is that some children with a high risk scan will actually have a normal IQ. And some of them may even have above normal IQ, and we certainly saw children like that. So just to go back to this summary slide, what we see is that the ultrasound risk categorization done in the first week or 2 of life is highly predictive of what happens at 8 years of age and on into adolescence and so on. But some children, even with a low risk scan, some children are going to end up disabled. In other words, having a completely normal ultrasound scan does not mean you can guarantee that a child is not going to have disability, and a premature baby. And similarly, this is not 100%. In other words, even if you've got a high risk scan and you've got loss of brain tissue, you've got a cysts or something like that, you may actually be normal. 25% have not got a disability, and 10% have absolutely no detectable abnormality on examination at 8 years. And the fact, therefore, that although ultrasound is helpful, it is by no means 100% predictive. That's a very important message when we come to talk to patients. The other thing to remember is that even term babies, if you have a term baby born in your hospital who has no detectable problems and who is discharged and goes home after 24 hours, what is the chance that that child is going to end up with disability? Well, it depends on your precise definition of disability, but it can be as high as 3, 4, 5%. In other words, the low risk category for prem babies is not that different from the risk, the general risk in the population at term. And that again is an important message to try to communicate. Following up, one of the fascinating things that happens in a lot of ex-prem children is its subtle white matter injury. And that's not the main reason we're talking today. We're talking about hemorrhage, but it's just a fascinating thing we saw. There's a lot of these babies had thinning of the posterior corpus callosum, and there are other subtle white matter abnormalities which we increasingly recognize as something which happens in ex-prem babies. This was a study which had again done in our cohort. This was done at the Institute of Psychiatry in some of our ex-prem babies, and they compared the grey and white matter distribution in adolescents who'd been born very prem at UCH compared with term controls. And interestingly, this is the grey matter up here, this is the white matter. And if you look at the blue areas, these are areas where the prem babies actually had increases in grey matter. And the brown yellow areas are where there was decreases. So there was decreases in grey matter in certain regions, but there were compensatory increases in grey matter in other regions. And this just emphasizes the fact that after the baby goes home from the neonatal unit, a huge amount of processes are going to go on over the following 10, 15, 20 years as the brain remodels, adjusts, revises, because of the extraordinary plasticity of the central nervous system. And that then reminds us again that it is not deterministic. As neonatologists, it's easy to think, well, what happens to your brain in those first few weeks of life is going to determine the rest of your life. And it just is not as deterministic and mechanical as that. The brain is a constantly adjusting rewiring and has an extraordinary amount of plasticity. That's just showing the same. And this is another example of the kind of rewiring. This is a fractional anisotropy map, and this is a normal adult brain. And the green fibers are orientated AP in the front to the back. The red fibers are orientated across between the hemispheres laterally, and the blue fibers are orientated out of the screen vertically, coming up at us out of the screen. And that's the normal pattern in the adult brain. And as you can see, there's a huge amount of tracts communicating antero-posteriorly, this so-called ventral stream, which is thought to be very important in the way the brain normally functions. Now compare that, just keep that in your mind. This is an ex-preterm brain of a baby who had a grade 4 hemorrhage. That's an HPI, a hemorrhagic parenchymal infarct. And you could see the post-hemorrhagic hydrocephalus. So this baby has got grossly dilated ventricles, and on this side had an HPI. And I think you can see with a big porencephalic cyst, which is now in continuity with the ventricles. And I think you can see, can't you, if you compare that now, this is the normal adult brain. Can you see how the pattern of fibers, the way they run in this very damaged brain, are quite different? But the fascinating thing is that this ex-prem child had actually gone to university, had a unilateral hemiplegia, but above average IQ. So clearly, the brain had managed to rewire itself at plasticity in order to function at a cognitive level very successfully. This I've taken from a chapter that in an older version of Neil Marlowe's of Rabelton's textbook of neonatology. Unfortunately, it seemed to disappear from the later versions of the textbook, but I found this quite a helpful summary, because Neil Marlowe had just summed together from all the literature and these percentages who were so-called normal and those who were disabled. Now, of course, you have to interpret this with a great deal of caution, because different studies use different definitions of disability. But the reason for showing this is that it basically shows the same kind of message that we got from the UCH study, that if you've got a normal scan, 92% are going to be normal, 5% disabled, according to Marlowe's work. If you had an uncomplicated hemorrhage, 88%, 7%, in other words, virtually the same. If you go back to intraparenchymal hemorrhage down here, HPI, then 38% normal and 62% disabled. So again, it basically shows the same picture, but again, notice that 38% in this study was so-called normal, despite a grade 4 hemorrhage, which we would normally say was very bad news. And so it's so important to remember that these lesions are not as predictive as you might expect. I'm coming to the end of this section, but just before I finish, I would like to say an important point, and that is that as you get to more and more preterm gestations, in other words, as you get closer and closer to 23 weeks, 24 weeks, and so on, the normal scan becomes less predictive. In other words, as you saw previously in the more mature babies, a normal scan, the chance of having disability was low, about 5–6% in the UCH study. If you just look at extremely preterm babies, these are all less than 1,000 grams. In fact, a higher proportion of babies with normal scans have problems at follow-up. 9% had cerebral palsy at 18 months, and 25% had a cognitive problem at 18 months. So just remember that a normal scan in an extremely preterm baby is not as predictive of normality. And that's because it appears to be you can have very subtle abnormalities of white matter which are not obvious on the scan. The scan basically appears normal, but which actually can lead to very significant problems in later on childhood. And when they looked in this particular paper to see what were the multivariate associations with cerebral palsy, this column, or with cognitive impairment, this column, what came out was being male. As we know, being male is bad for you at every stage of life, including when you're very preterm. Being part of a multiple birth, that's not surprising. Low birth weight in itself is independently predictive of poor outcome. Interestingly, for CP, mechanical ventilation seem to increase the risk. When you come to cognitive impairment, it's other things like maternal race, maternal education, maternal insurance, this is from the States, became quite predictive of cognitive impairment. And then the last thing to say is this, and when I first read this, it completely blew my mind. But I think this is a very important message which is not communicated enough, and that is a study in which they took all babies who were born very preterm, so less than 33 weeks, and they simply looked at the effects of the parents' socioeconomic background with the long-term outcome at adults of these preterm babies. And what they found was that the parental education made a huge difference on the likelihood of having an adverse outcome in preterm babies. So in the lowest parental education group, that was parents who did not complete high school education, 1 in 6 of the ex-prems had severe problems in cognitive and neurosensory functioning, and 2 in 5 had problems in everyday activity. And you compare that with parents who completed college education, so that's tertiary educated parents. Instead of 1 in 6, it's 1 in 14 have severe problems in cognitive, and instead of 2 in 5, it's 1 in 8 had problems in everyday activity. So what this shows is that the childhood exposure that this ex-prem is exposed to can have just as big an effect, even if more of an effect, than what happened in the neonatal unit. And again, as neonatologists, we tend to forget that. We think that what happens in the neonatal unit is the most important determining factor, but it isn't. It's what happens after the baby goes home. Now, why is this so important? Well, because this is a reason to give parents hope. To say the way you care for your child, yes, your child may have some problems, but the way you care for your child can make a huge difference over the subsequent years. You are the most important person for your child, and therefore you mustn't destroy hope. When we speak to parents, as we'll see, one of the most important things is not to destroy hope. So perhaps this is something we can discuss if you're interested in, and these are perhaps rather out of date, but I think you can use the cranial ultrasound scan in order to decide what kind of follow-up is required for your child. And if you have a low-risk cranial ultrasound scan, you can argue that because your risks are not that much greater than in the general population, you don't require detailed follow-up unless perhaps you're less than 28 weeks. Conversely, if you come in the high-risk scan, then I think you can argue that you should be immediately referred to a multidisciplinary child development team. You don't wait to see if the child is going to develop cerebral palsy or other difficulties. In fact, you should warn parents and say that right from the beginning, this child should be getting intensive input. You warn parents of long-term risk, but don't destroy all hope because you might be wrong. So in summary, neonatal cranial ultrasound is a valuable tool for the immediate management and long-term prediction of outcome of preterm infants. It can help to predict long-term outcome, but not all normal scans lead to a normal outcome, and not all high-risk scans lead to severe disability. And so our first duty as doctors is not to do harm. And it is possible to do harm just by the way we talk to parents. Primum non nocere, first, do no harm. Okay, thanks very much. I'm going to stop there. And I'm very happy to discuss anything that wasn't clear, to repeat anything, or to answer any particular questions.
So I'm going to open questions to the audience. So would anybody like to ask Prof any questions? We have a few from the audience on YouTube, which I will ask Prof after the audience has gone first. So does anybody want to go first? So Anna, go for it.
Hi, thanks, Dr. Wyatt. That was very interesting. I just wonder, in terms of that last slide where you mentioned about the parents' education level, do you have any information about sort of the distribution of gestation in those, and whether it's sort of affected by the fact that people from a lower socioeconomic class are maybe more likely to have extremely premature babies, if you know what I mean?
Yeah. I mean, obviously, you're right. There is some kind of interaction there. We know that there is a statistical relationship between parental education and your risk of having an extremely prem baby. But I think this was something that was looked at in the paper. I think it's there, but it's not as strong. It certainly doesn't explain the findings. And you know, we know from experience that I've seen many parents with social class 1A backgrounds who had a baby at 24 weeks. So you know, it's certainly a significant number of babies who are born extremely prem do come from very good backgrounds. In fact, as I'm saying this, I'm just remembering a 23-weeker who I cared for a long time ago, from professional backgrounds, did very well, and is now at university, age 20, at 23 weeks. You know, so that would be an example of an outcome which was definitely positively influenced by what happened to her after she went home.
Thank you.
So anybody else have the hands raised? So, Prof, we have a question from one of the participants in the audience, and it's a fascinating question, and it's really looking at your experience, but just for extremely preterm babies who are breastfed versus formula fed, what is there any evidence on long-term neurodevelopmental outcomes being better for the breastfed cohort?
I'm not completely up to date on the most recent literature, but my memory of the literature is that there is some evidence of breastfeeding having beneficial effects. I mean, the beneficial effects of breastfeeding is partly infection resistance. The lactobacillus, bifidobacillus promoting factors in breast milk are extremely helpful in impeding other pathogenic bacteria like E. coli. So it's partly the anti-infective effect, and it's partly thought to be there are, you know, magic components within the breast milk which are particularly promoting brain development and so on. However, the problem with breast milk is lack of calorie intake. Yeah. Because breast milk is less calorific, less calorie dense than modified premature formula. And so paradoxically, we also know that calorie intake is a vital factor in long-term developmental outcome. And it's been shown quite nicely that the rate which the head grows in the neonatal period is quite predictive of long-term developmental outcomes. And so the babies who get chronically undernourished and who fall off centiles on the neonatal unit have an increased risk of having cognitive and developmental problems. So breast milk is not a panacea. And I remember from my own clinical experience that sometimes we found that it was babies who were having breast milk often didn't have the same kind of weight gain as babies who were receiving formula. So there is a place for supplements, therefore, I think. Unfortunately, when you use supplements, you often minimize the anti-effective effects of breast milk and the anti-NEC effects of breast milk, but you maximize calorie intake. So there's a kind of balancing process going on there.
So one of the questions that we have is that we often have scan protocols in the neonatal unit, and you know, with babies who are extremely preterm, we scan them at birth, 3 days, 7 days, and there's additional morbidity that takes place with other comorbidities like NEC, late onset sepsis. And the difficulty for us becomes, I mean, quantifying what the head scan means in the context, not just of prematurity, but those additional morbidities. And I'm just curious how, in your experience, you pull those things together. So that might be pulled together in the context of wanting to stop intensive care for a baby who's obviously got very severe PVL, who might have very severe chronic lung disease, not coming off the ventilator, for parents who want to carry on, versus a situation where this baby is going home and is actually neurologically normal, and the conversations are so different. And it's something that me as a consultant with, you know, just 10 years experience, it's something I really struggle with. And I'm just curious to know what your approach is in those circumstances.
Yeah, thanks. I mean, they're very interesting and challenging. You know, this is where, you know, medicine is not just a science, is it? It's an art. And we're trying to take all the information that's available and then use our experience and our knowledge and our wisdom to try to advise parents. And that's the real art. And it's by no means easy, but the way I think about it, both in my own thinking, but also the way I often speak to parents about it, and that is, I think of it like a jigsaw puzzle, that what we're trying to do is put all the pieces in place so that we can see the whole picture. And it's important to recognize that although different pieces are important, any one piece does not tell you the whole picture. And it's important, therefore, for parents to understand that, for instance, the scan appearances is one piece in the jigsaw, or maybe several pieces in the jigsaw, but it's not the whole picture. And often my experience was that parents often latched onto the scan, and they often latched onto what someone had said to us. Sometimes it was a junior doctor who said, "Oh, I don't like the look of that," or something like that. And it was like that comment became completely dominant, that the parents couldn't think of anything else but what one doctor said about the scan, and they get it completely out of proportion. So I think trying to help parents to see that in trying to look towards the future, and yes, we all have to do that, you try to build up a picture of all the different bits of information and pull it together. And so, for instance, if you're talking about a baby who's had a very complex history, where maybe they had, hemorrhage in the first few days of life, then they had a bit of recovery, and then they had a massive collapse because of NEC, and they had and sepsis, and then prolonged chronic lung disease, and then they've eventually sort of got better. And now if we look at the scan actually isn't looking that bad, and it's, it's got some ventricular dilatation, but there's no obvious PVL cysts, So I've got to try and say, well, let's try and build up the picture here. Yes, we know there was some hemorrhage. Yes, we know that there was that bad episode of NEC. Yes, we know there's chronic lung disease and not prolonged oxygen requirement. But on the other hand, the brain is growing, the baby's growing. There's no obvious cystic changes developing on the ultrasound. And I would say I'm cautiously optimistic. I recognize that, yes, there is a small but significant chance that your baby is going to turn out to have problems, but I really don't think you should be desperately pessimistic and say, oh, it's all going to be terrible. And I think it's possible for us as clinicians to pass on our concerns and worries onto the parents. And frankly, you're not doing them any favors. You're filling their heads with a whole load of things to worry about, which isn't going to help them when it comes to caring for their child. What does a parent need to know? What they need to know is that what they do makes a difference, and that they need to be motivated and positive about the fact that they can do the best for their child. And that's why I think, although we can't hide risks, if people ask us what are the possible risks, we do need to emphasize the positive outcome. And I often used to talk about babies where had done so much better than I had thought, and that included babies with cysts, with PVL. I can remember one child who had a huge great bleed into the temporal region and ended up with a big temporal cyst. We happened to have a visiting neuroradiologist, I think from the States, visiting the unit, and he looked at the scan and he said, oh, that's absolutely catastrophic. I've seen those, these children are absolutely damaged. And I remember I sat down with this mother and I did a sort of, what we used to call a black cap job. I would tell her, I'm terribly sorry, but there's evidence of really quite severe brain damage. And in fact, this child, I then followed up this child in the follow-up clinic. I saw her repeatedly and she was completely and utterly normal. And there were no neurological signs. She was making normal developmental progress. There was nothing to find. And I felt really embarrassed because I could remember having, warned the parents, and I talked to the parents about that, and I said, look, I got it wrong, and I'm sorry because I fooled you ahead with a whole lot of really bad stuff, and it wasn't true. That, incidentally, this is why it's so important for neonatologists to go to the follow-up clinic. If you spend your whole time in the NICU and you don't actually see the children coming through the follow-up clinic, you are not going to be able to counsel the parents properly and realistically. And I think it's absolutely essential that neonatologists are actually spending time in the follow-up clinic, and not just up to sort of 6 months, but actually seeing children at 4 years and 8 years and school age and so on, and seeing what's happening to them, because it completely changed my view. You know, quite often I would be on the neonatal unit and I'd hear so many people saying, oh, isn't it terrible? We've got another grade 4 hemorrhage. Oh, it's catastrophic. Everything's terrible. I just sometimes wonder whether we should shut the neonatal unit and give them all potassium chloride. You know, that kind of terrible fatalism. And I would say, I can't believe you're saying this, because I've just come from the follow-up clinic and I've just seen a whole succession of ex-prem babies, some of them with CP or with other problems, but actually they're living their lives and they're very, very grateful, and the parents are very, very grateful, and it's much more positive and life-affirming than what you sometimes think in the neonatal unit. So we've got to try and find the balance, but this is why I think first do no harm. We can do a lot of harm if we fill our parents' heads with lots of gloomy prognostications going on and on. You know, oh, sorry, I'm on a pet topic here, but it's sometimes, I make the contrast. You know, imagine you're the pediatrician and you're doing the postnatal checks, and here's this term baby, and it's a completely normal, healthy term baby and about to come home. Imagine if you were to turn to the parents and say, now you do realize, don't you, Mr. Smith, that your child has a 1 in 3 chance of getting mental health issues. I just felt you ought to know that. You do realize there's a 1 in 6 or 7 chance the child's going to need special educational help. You do realize that social deviancy is very common in adolescence, and you need to prepare yourself for that. You do need to realize this child might develop terrible, devastating illness. I mean, for instance, road traffic accidents is a very major problem in young children, and so on and so on. We don't do any of that. We would think it was utterly pathological to say that to a child, to parents with a term baby, even though all those things are true. And yet when we've got a baby born at 28 weeks, we say, oh, you do realize you could have educational problems. You do realize you could have cerebral palsy. You do. So why is it different? Why do we feel that with a term baby, our responsibility is to say, congratulations, she's a lovely baby? Whereas when they're born at 28 weeks, we think our responsibility is to fill their parents' heads with a whole load of terrible, gloomy stuff.